hopefully this works. So can you see it okay now?
We can indeed, yes, perfect.
Okay, that's great. Sorry, everyone, some tech issues there. So I'm Kate Wales. I'm the head of safeguarding and supervision for Practice Plus Group, and I'm also the professional nurse advocate lead. Today, I'm going to give you a whistle-stop tour of the introduction to the role of the professional nurse advocate and how we as P&As can support safeguarding supervision within health injustice. So within health injustice, we have a multidisciplinary workforce, including registered staff, non-registered staff, and allied health professionals, and we provide care to thousands of patients within male and female prisons, immigration removal centres, and our YOIs as well. We provide exceptional levels of care to both primary care, mental health, and substance misuse patients using a multidisciplinary workforce. And we deliver care in settings that are not usually like your normal hospital or community settings. So in terms of thinking about responsibility, it's everyone's responsibility for safeguarding. But the governors and the directors have the ultimate responsibility within prisons and immigration removal centres over safeguarding. And they are unable, for those patients who are unable to protect themselves from abuse or neglect, and as a result of having care and support needs. All staff working in prisons have that responsibility to work together, understand what safeguarding means, and report any concerns. And ultimately, under the Care Act 2014, the prison have a legal obligation to carry out any investigation and any, obviously, Section 42 inquiry. Okay. Perfect. So the role of the professional nurse advocate. So the professional nurse advocate was introduced in 2021. It was launched by NHS England by our Chief Nursing Officer, Ruth May, where it highlighted the need for nurses to be equipped to really understand the demands of their role and how staff may be feeling. Underpinning the professional nurse advocate role is a framework called the AEQUIP model, and that provides a real strong structure to really focus and support the well-being of our staff, compassionate work cultures, and really enabling quality care, that purposeful education and psychological safety by really facilitating restorative clinical supervision. I'm going to obviously come on to that in a minute. So the professional nurse advocate role is a leadership and advocacy role whereby these P&As have the knowledge to support staff to ultimately improve their health and well-being, develop education and training to support skills and knowledge, and that can be around a variety of different subjects, and support quality improvements within our workplaces. So what we want to do is cultivate that real psychological safe space through clinical supervision. So we have all experienced at some point, I certainly have, both in our personal and professional lives, really challenging and difficult situations. And we know that that can really impact on our emotional well-being and how well we actually perform in the workplace. There's evidence clear out there that there is that strong synergy both between our own well-being, so workforce well-being, and patient outcomes. And obviously, we've seen from the Francis report into the findings of the Mid Staffordshire inquiry, where staff have felt really overwhelmed by their work and the detrimental impact that has on patient care. We know difficult emotions are often evoked because of the nature of the content of the work, and particularly within a health injustice setting, and that the capacity of the professional to remain resilient within the role really depends on that strong support systems. And that's why safeguarding supervision is so fundamental and key to this. So in terms of thinking about then what actually restorative clinical supervision is. So restorative clinical supervision is a model of clinical supervision which is really focused on the emotional needs of our staff, supporting the development of resilience by what we want to do is ultimately reduce stress and develop personal growth and well-being. We want conversations to be reflective and supportive with that open and honest feedback, and within safeguarding supervision, that's really essential. And it's essential that it's a trauma-informed approach to managing situations, which really encompasses that curiosity and civility, and that we have a multi-agency approach to that. And that ultimately then will empower that individual and staff teams to really develop that strong leadership and ultimately improve our patient outcomes. What we have seen is that the learning from restorative safeguarding supervision has been that there's a need for professionals to really remain resilient remain resilient and place themselves at the centre of that care to be able to deliver good quality care. And that's underpinned by the safeguarding session, and that's not separate to that. So the two are really combined as one. So we want to think about actually why safeguarding supervision is important. So restorative clinical supervision is obviously a focus around safeguarding supervision, and we know that there continues to be that confusion regarding the models of clinical supervision, particularly in health settings. We've obviously seen that there's little guidance from policy nationally and locally, where supervision is often discussed as being imperative, but it's not described in a way that actually supports the practitioner to really understand what the contents or the purpose of the supervision needs to be in order for that to be effective. So actually, when there's an absence of that guidance, that really makes safeguarding supervision quite vulnerable to becoming a space that's just solely driven by that organisational demand, a tick box exercise to be assured that the practice is actually safe. So just thinking about why safeguarding supervision is essential is that just some points on the screen there from my own thinking is around ambivalence and ambiguity. It helps prevent some of this conflict, that conflicting interest and principles between our own stakeholders. Managing power and authority issues that can be quite demanding and challenging actually, and can really isolate staff within the team. It helps develop self-awareness and the relationship between staff within a workforce. Certainly from a health injustice perspective, the complexity of some of the issues that we see from a safeguarding perspective, that is really complex, that we see amongst our patient population, particularly when you're thinking about the toxic trio. A degree of discretion and judgment, strong, powerful values and moral dilemmas that can really come to play in safeguarding supervision and challenge our own thinking, and actually strong emotional issues. When we form connections with our patients, that can be really difficult at times. So when we start to think about why safeguarding supervision is important, we can then think about the competence matrix. So the competence matrix really thinks about where we actually are in terms of level of our thinking. So when we think about conscious competence, that's where we're in a really firm, strong position. So that's about what I know and I can do it. Real clear, transferable skills, and that can be explained to others. I can articulate that picture to others. The conscious incompetence, so that's where we start to challenge as a supervisor, and we'd be really thinking about challenging the supervisee. So the areas of me as a supervisee, openly acknowledging the gaps or the weaknesses, and the supervisor challenging that as me as a supervisee. And the development zone, so the unconscious competence, so what I know or can do without being conscious of how I know it. Hard to explain to others, and then that's often lost. What we see quite regularly amongst teams within healthcare settings is that toxicity amongst the workforce and the turbulence, but there's still room to develop. But then when we come into that real danger zone, and why safeguarding supervision is so important as well, is that unconscious incompetence. So things which I'm unaware of, I don't know, and others may see these gaps, but I don't see it. And actually that can then develop into performance problems. So we absolutely acknowledge there continues to be confusion regarding models of clinical supervision, and particularly, as I've mentioned, in health settings. And obviously what we want to see is that we want the supervisor to be able to understand and support the supervisee within their current situation. So the supervision space should be honest and open in order to allow a focus on restorative processes, in order to enhance our own thinking, as well as enabling an approach which challenges that work to really critically reflect on the assumptions that are really underpinning our approach to our work, and particularly when we're thinking think family as well. The space needs to be located within a framework which respects the supervisory relationship as a vehicle for really promoting good practice, but it's equally clear that the supervisor is not responsible, not only to the supervisee, but also within the organisation as well. And also what's really important is the containment of that supervisee and their capacity, which is essential to restorative safeguarding supervision, to really slow down that supervisee in their thinking, to be able to support them to reflect appropriately on the incident, which is really key. And this is a significant skill in restorative supervision, really creating a safe space that feels supportive, enhances the learning for that individual. So what we would need to consider then as a safeguarding supervision session, we need to work at a number of different levels in order to draw out and really explore the complexity of the work and support the practitioner in their ability to really make safe, sound professional judgments. We need to develop emotional intelligence around our safeguarding practice, and that's really fundamental in the importance and a point to where restorative skills are developed and are crucial to effective safeguarding supervision. So we need to think about the rule of optimism, which is in terms of why we behave in our own thinking as a professional or our own actions when indicators are suggesting otherwise. We make our own assumptions because of our own beliefs and personal values or our own experiences with particular safeguarding incidences. We need to really reflect upon that. A lack of professional curiosity to really diving into what's going on here. Let's unpick this together. Cultural sensitivity, so our own beliefs and teachings and what that is within the cultural context. Disguise compliance, so what we as professionals want to hear. And as I mentioned before, not recognising the complex needs, so the toxic trio. And as what we've seen from Safeguarding Adults Review time and time again is around information sharing and siloed working. Practitioners being overwhelmed and burdened, which is again why so important that our restorative approach to safeguarding supervision is essential. And then finally, confirmation bias, and that's about how we all tend to prefer or what we think confirms that, but actually in terms of what we already believe rather than challenging that as well, so confirms our pre-existing beliefs. And what's really important within the session is that we need to think about who we're supervising, how to question that at times, what we can talk about, what feels comfortable to talk about, and actually what's really important is how we provide feedback to that individual as well. So thinking about the 7 Ps of safeguarding supervision then. So ultimately, the presenting problem, that's about summarising the main concern and how the individual's been impacted and the family, the patients that we're working with. The pattern and onset, so when did then vulnerabilities start? What patterns have we noticed? Predisposing factors, so what's our understanding of historical influences which present as the vulnerabilities? Precipitating factors, so what is our understanding of the trigger events or occurrences that happened prior to this? Perpetuating factors, so what's likely to influence or maintain them difficulties or the concerns that we may have? Our protective factors, so what could act as a buffer against poorer outcomes? How can we mitigate risks? How can we support the patients? And ultimately the prognosis, so really taking into account all of the above. What is the likelihood of them concerns or difficulties being halted or continued, and how can we safeguard both our staff and our patients? And the essence of really good safeguarding supervision is the capacity, as I've mentioned, of the practitioner to think, reflect and develop their own solutions around what needs to happen, and next involving our patients. And that's really key, that we involve our patients, and our patients are at the centre of that. And the restorative nature of the session is therefore really paramount to support the professional in their capacity to be able to do this really effectively. So just some key points then to think about to end the session. Safeguarding supervision needs to be supportive to support the professional's capacity to really think, feel restored and slow down. Effective safeguarding supervision combines critical reflective practice and thinking within that real restorative approach, which the professional nurse advocate can support and bring about that self-awareness. The new integrated restorative model of safeguarding supervision ensures that there's an appropriate degree of restorative efforts, and that they're combined with real mature space to explore our assumptions, the complexity and the impact of our work in the dynamics that we're working in. And finally, organisations need specific guidance around the type of supervision being adopted, rather than an assumption that any form of supervision is beneficial. So whilst we've adopted a restorative approach to safeguarding supervision within Practice Plus Group, one size doesn't fit all, and that may not be suitable for other organisations. And that's it. Thank you.
Now, hopefully I'm not putting you on the spot with this question, as I know it's something you answered similarly in Liverpool a couple of weeks ago. Something that was discussed, the question came up around who delivers the supervision and kind of embracing a more of a multidisciplinary approach. Would you mind sharing some of the stuff you've done at Practice Plus around that? Because I know that for some colleagues there'll be some eyebrows raised, but I know that you'll be able to kind of talk about some of the benefits of that as well.
Yeah, absolutely. So we're really keen within Health and Justice to have a multi-agency approach to both our models, to all models of supervision, whether that's restorative clinical supervision or restorative safeguarding supervision. So whilst within safeguarding supervision, we have our local safeguarding leads and our regional safeguarding leads supporting and facilitating safeguarding supervision. What we want to try to do, and the model that we're adopting, is that it's a not one size fits all model. So you wouldn't have a nurse supervising a nurse. What we're really encouraging is a multi-agency approach where you may have, for example, a GP supervising a nurse, or a paramedic supervising a GP, for example, so that there's a real understanding and shared learning across Health and Justice, because we all acknowledge that we have all different beliefs, different values, and that we can all learn so much from a shared system approach. So we're really keen to adopt a multi-agency approach to our model of supervision across Health and Justice. We're also taking steps within certain sites where we're bringing the prison into that as well. So where we've had a complex issue, and that might be a complex safeguarding issue, for example, we are supporting our prison and immigration removal colleagues to come on board with that supervision session, because they bring a whole different perspective into that as well. So we're really encouraging a full multi-agency approach to supervision within Practice Plus Group.
Have there been any particular barriers that you've faced? Because it's one of the challenges, and it's something which is reflected in the forum and a number of providers over the years, is often that, and as you reflected at the start of your presentation, everybody recognises the value of supervision.
Yeah.
But actually kind of carving the protected time, and not unfortunately, but it's really important to recognise that also means protected resource for that, because time is money, whether you're independent, public sector, kind of, it's our staff need that, but there can sometimes be organisational barriers, and I'm just wondering if you kind of came across any during this journey at all.
Yeah, so right at the beginning, so when we started out really trying to embed a model of supervision across Practice Plus Group within the Health and Justice division of Practice Plus Group, we carried out a survey, and what was really key from that survey that we sent out to our workforce was that 75% of our staff, and that's all staff, valued supervision, which I felt was really powerful. I didn't think that high percentage would be returned in terms of staff valuing supervision. I thought it'd be a lot lower. But in terms of some of the barriers that you've mentioned were key, and that I wasn't surprised. So some of the barriers that for embedding effective supervision was time. So staff being given the time, so being released from their rotas to carry out supervision. Resources, so having a room. So what you may think sounds really silly, but in a prison setting, that's really difficult at times to find a room to even carry out supervision in a safe, quiet space, it not being noisy and loud, and that's conducive to a supervision session. And the skill approach, so actually the supervisor having the right skills to be able to deliver and facilitate that session, but also the supervisee coming to the session and understanding what the session is about and what they even talk about. And then what was really profound was that actually there was a fear that if something was disclosed in a session around particularly their mental health, or that if they were to raise something, that there would be a punitive approach from that, or that they would be punished almost. And there was a fear that if they was to disclose something, what would be the repercussions of that? So we've worked really hard within Health and Justice to really adopt a safe space for people to be able to talk safely, open, honestly. And that's about creating that real psychological safety amongst our peers. And that's why it's really important to have that multi-agency approach, that we respect others' views and opinions, cultures and belief. And that really helped towards creating that real psychological safe space for staff to go, hang on a minute, I've seen this, I've witnessed it, I've heard this, I want to talk about this, and it's okay to talk about this within this safe forum. So I think what we've seen as barriers barriers are no different to probably what other challenges other organisations have seen, but it's about us championing that work and kind of keep really driving in the momentum around the importance and the benefits of safeguarding supervision and how we can really support staff's well-being with that as well.
Thank you, thank you. And would it be fair to reflect that some of those early barriers, especially around the anxiety and the fear, as people have found the value of supervision, have they kind of dissipated, or are new barriers popping up potentially in their place?
So what we're seeing now, which is a real good positive cultural shift, where we've seen incident reporting, where staff are saying, I've had reflective supervision, I've had access to a professional nurse advocate, I've had safeguarding supervision, which is absolutely so powerful and amazing to see within our incident reporting, that we're really creating this safe patient safety culture where staff are reaching out and saying, actually, it's my right to have supervision, and staff are accessing it. So what we're seeing is a real shift towards a positive cultural change in terms of staff saying, actually, I want to have supervision and I know this is right for me, and actually saying I'm entitled to it. So we've seen a real cultural shift in that, which has been really, really positive, Phil.
That's fantastic. And you just got a little kind of round of applause emoji kind of bouncing from the chat there for kind of reflecting that on behalf of your colleagues. Just because I'm very aware there may be an opportunity for us to have the afternoon break start a little bit early and give people an extra 5 minutes. Would you, just from a P&A point of view, because obviously we've got, it's now built into the NHS standard contract, and a lot of providers and kind of colleagues who are joining this from across the sector may have heard about it, may be involved personally with it, or may not have a clue what that actually means for their services. And as you know, there's a really specific ratio of P&A provision and stuff like that. So would you mind perhaps just wrapping up with a very brief description of what the expectation is for those providers with an NHS contract, just to help tie things together?
Yeah, so in a small nutshell, so just quickly, as I mentioned at the beginning of the presentation, the professional nurse advocate role was launched at the back end of the pandemic. It was initially introduced back in 2017 into midwifery services, and then it was rolled out into critical care, where it was recognised that staff needed restoration, thinking time and space away to really restore themselves. And actually it really highlighted the need that nurses need to be able to manage the complexity of their workload, but also have that equally balanced with being restored and a focus on their support, a focus and support on their own well-being as well. And ultimately what's been found from research out there is that then develops compassionate cultures. So the standard expectation via NHS England is that by 2025, March 2025, is that all organisations will have a 1:20 ratio in larger organisations. In smaller organisations, that's 1:5. A 1:20, sorry, that's the other way around. To have a 1:20 ratio where there'll be 1 P&A to 20, obviously, supervisees. And what that has shown is that that will then effectively drive leadership and clinical quality care amongst the workforce as well. I think I've summed that up in a nutshell.
No, it's perfect. Thank you. And with it, liken it to the importance, like everybody has a model of supervision which they prefer, either delivering or receiving. And we have a lot of conversations, and there are conversations amongst the RCN as well at the moment. And I wonder if a nice way of phrasing it is like, whether you have kind of porridge or toast, it's about the importance is having breakfast. So whether your preferred model is a restorative approach or something a little bit more kind of directly clinical and almost process driven, the importance is the value of that space. And P&A is another kind of tool in the toolkit.
Yeah.